hear me. Perfect. Gila, first of all, first and foremost, I want to thank you for your leadership in Yesh Tikva as really the CEO, CFO, grant coordinator, person who pays the bills. This is, this is truly a labor of love for you, and I appreciate you from across the country. And I thank you for continuing to push through the kind of all the barriers that are out there for people that are seeking infertility supports. And I just respect and honor all of the work that you do. So thank you for that and for always including me in it. I'm Dvora Entin. I'm the clinical consultant with Yesh Tikva. I'm a licensed clinical social worker, and I also training as a perinatal mental health specialist. I have a certification through Postpartum Support International. So my work really relates to everything within the reproductive years of a woman's lifespan. So infertility, pregnancy loss, and perinatal mood and anxiety disorders. And the fact that we're having these kind of really important conversations is so critical across the lifespan, not only as a provider, as a mental health provider, but as a person who interacts very often with the woman or the couple who are dealing with infertility. Knowing that we're talking about all sides of it is so important to this, to the growth of awareness and education, and just the general sensitivity that we need to continue to grow as a broad community around issues of infertility and women's reproductive health and men's reproductive health. So tonight we really will be focusing on kind of two angles of infertility. We're talking about male factor infertility, when the primary issue of infertility is within the male, within the man. And then we will also be talking about what it means to be a man and involved with his partner in their experience of infertility, be it unexplained infertility, be it low ovarian reserve, be it multiple pregnancy loss. So we're looking at it from two angles. And when I ask my questions to our esteemed audience, I will kind of direct the question. I'm sure it will be obvious, but just in case, I'll clarify, are we talking about male factor or general male infertility issues? So tonight we have joining us Dr. Bill Petok from Maryland, who is also a therapist, a psychologist, who's an expert really. And when you put it out there on Facebook and you say, who out there are the experts in infertility for men? And every single person goes, have you contacted Bill Petok? You know that you truly have the expert in the field. We also means that we need more men going into this field. So we're grateful that you have chosen to be with us this evening and to have spent some time giving me a more personal conversation earlier in the week. Make sure you check that out on our Instagram and Facebook pages, as well as on the website. So Dr. Petok will be addressing from a deep mental health perspective on these issues. He's also, by the way, a clinical professor through Jefferson as in their College of OBGYN, right, and psychiatry.
Correct.
So
well, OBGYN, I didn't make it, yeah, just OBGYN.
The psychiatrists aren't ready for you yet. We'll give them a little bit more time.
Apparently not, yeah.
Eventually we'll get there. And then we have Dr. Werthman, who is joining us from California as well. He and I sat on a panel a number of years ago, and he's a urologist that also has a specialization specifically in male factor infertility and working with the men on the biologic issues that prevent them from conception and from fertility. So we will talk with you. Dr. Werthman, thank you for being here this evening. I see you
Thank you for inviting me.
Daylight left. A pleasure. And then finally, we also have Akiva Schreiber. Is that you, Abigail?
Yeah,
is
that
yes. Hi. I see you're like on the down low right now. So we're glad to have you. You can always rename yourself as Akiva. Akiva is joining us this evening as a survivor, as a parent, and as a person who will be talking about his own experience in dealing with he and his wife's experience of infertility. And I must say that I think of all of us joining tonight, many of us can hide behind screens. We can hide behind the privacy of nobody knows who we are. But to be able to step into the limelight and to say, I'm ready to talk and I'm ready to make sure that our voices are heard and really listened to is extraordinary. And so I'm really thank you, Akiva, from not only me, but from everybody else that I know you will impact. When we talk about difficult stuff, we impact it not just in the people that are on the call, but it ripples out across families and future families. So thank you for being that person with us tonight. So I think that I'd like, in order to set the stage for the conversation, I would like to start out with kind of what is male factor infertility. And I'm going to ask Dr. Werthman if you can address that. What are the top 2, 3, or if there really are much more than that, issues that men deal with that prevent them from creating a family? So why don't we, and I'll make sure that all of us who are not speaking should probably be on mute, just to make sure there's no cross interference.
Thanks. So I think you have to start with the broader question, which is what is infertility? How is that defined? And I mean, the standard definition is couples who are having unprotected intercourse for a year and being unable to conceive. And then you try to break that down. If once you realize that somebody might be having a challenge, then you try to figure out what that challenge is. And the standard way that people enter into this world usually is through the gynecologist, unless a man knows that he's had some sort of history where he may have a problem, but that's pretty unusual. The typical thing is a woman goes to her gynecologist and, says, hey, we've been trying for X number of months or years, and, what should I do? And it'll include a workup. And part of that workup is to have a semen analysis done. And so as soon as a man goes in and has an analysis, it comes back to the gynecologist typically, and they'll look at it, and if there's some sort of abnormal parameter, they'll either repeat it or they'll refer the patient on. So in the context of general infertility, if that semen analysis comes up abnormal, then we start looking and looking to explore whether the man is having any sort of component into that process. I guess English is my second language. It's been a long day. I didn't quite come out exactly right syntactically, but whether there is any issue going on with the sperm or the men's health. And usually the first test is a semen analysis. If everything looks normal, then typically it's given a stamp and a couple moves on. Now, clearly, because it's normal doesn't mean there's not a problem, but usually that's the general way that this thing goes. So with male factor infertility, which is probably more common than recognized in the outside of the infertility world, it's generally regarded as an abnormal semen analysis, where either it's part of the couple's infertility, where there were challenges with the wife as well, or the wife has no issues that are identified, and something is identified on the male side of things. Now, I'm just using the semen analysis as an example. It goes much bigger than that because, truthfully, what's as or more important than the semen analysis is a man's history and physical. But because we don't start with that, we start with the semen analysis, we're going to leave that for later. But the most common things, truthfully, are lifestyle issues, health issues. When I say lifestyle issues, it could be smoking, it could be marijuana use, drug use. It could be too little ejaculation, too much ejaculation, wrong timing. Those obviously are not physiologic issues, they're behavioral issues. It could be sitting in hot tubs, it could be too much alcohol. There's a number of different things that are on the behavioral side of things. And then certainly there are physiologic issues such as varicocele, such as blockages, medications. All these things can play roles.
So when we're talking about, just to clarify one level deeper on that, when we're talking about from a physiological standpoint, what are the primary issues that you could see in the sperm that would create a problem with fertility?
So let's go back to what a semen analysis actually analyzes and what it means and what it may not mean. So just generally, a semen analysis is not a fertility test, meaning that a normal semen analysis doesn't mean that a man is fertile, and an abnormal semen analysis does not mean that a man can't have children or is infertile, right? A semen analysis is a snapshot in time, and sperm production and the quality of sperm varies over the course of time, and we're just checking snapshots. So on any given day, someone who could be quite fertile can have an abnormal semen analysis, and we even have graphs of people who went in and frequently gave semen analysis who were fertile, just to kind of get an idea of what normal could be. And you see these counts go from hundreds of millions down to zero at some point over the course of a year, and then come back up. So we have to be very, very careful when we interpret these tests as to what they actually mean. And that's why the history and the physical also comes into play, plus maybe more than one semen analysis needs to be done to, if it's abnormal, to see where someone really is at. But the main parameters we look at are the semen volume, the count, which is actually a concentration, how many sperm are in every milliliter of ejaculatory fluid. We look at the motility, which is the percentage of sperm that are swimming. And we look at the morphology, the shape of the sperm. Now, what's interesting and frustrating at the same time is, through the course of my almost 30-year career, the parameters of what's normal on a semen analysis change. Seems like every 4 or 5 years, every time the World Health Organization rewrites the manual. So then I scratch my head and I wonder, and I see semen analysis from different labs and different hospitals, and one says 60 million is normal, one says 20 million is normal, one says 15 million is normal on the morphology, 30 million is normal, 30% normal is normal, 14% normal is normal, 4% normal is normal, and same thing with motility. Anywhere from 50% is normal to 32% in the latest World Health Organization manual is normal. So it almost seems to be a moving target, and I wonder how can that be when physiology didn't change, and yet the parameters change. And maybe Dr. Petok wants to comment a little bit on that, just in general.
I'd be glad to. I think probably the most important parameter is it only takes one, and I think we'd both be in agreement on that.
Right.
The problem is, the good one, and how does that good one get to the egg and fertilize it is really the challenge in this situation.
Wow. It's fascinating to hear all of the, how flexible the data can be over time. And I think that's probably lends itself to probably a lot of the frustration that families who are dealing with these issues are feeling as well. And that, I could have nothing's particularly concrete. Probably the hardest thing I always hear is the unexplained infertility, right? That same idea that I don't have good concrete data that gives me information about what I'm dealing with. So I think before we move on to like kind of a conversation around treatment, what I would like to hear, if it's okay with with all of you, I'd like Akiva to take the lead in telling his story and putting a face to the story as to, this is the data. And then I would like to hear if Akiva would be kind enough to share with us what his experience has been in his story as Akiva. Go ahead.
Okay, so the microphone's working, correct? Okay, good. I guess my journey sort of started off in 2014. I had gone in for a regular physical, not knowing anything was wrong, and my doctor just was like, "Hey, you should probably get this checked out. Here's a urologist, and let me know what he says." So I went to the urologist. I did the semen analysis, as Dr. Werthman was talking about, and my results came back as 0. Not 1 million, not 50 million, but just 0, not even 1. He's like, okay, it's the first time, let's do it again, see what happens. And I did it 3 times, and each time it came back as 0. And at that point, the urologist essentially looked at me and said, it doesn't look like it's going to happen for you. You should probably just go and adopt kids, and good luck with your life. And honestly, to hear those words at a point in our life when we weren't yet trying to have kids, but obviously wanted kids, was just devastating to both myself and my wife, Abigail. And we just didn't know really where to go from there. Fast forward now till the winter, January of 2015, and Abigail got involved in an event where Ellie Solomon, founder of Yesh Tikva, or co-founder of Yesh Tikva, spoke about her own journey, where Abigail became inspired to then share our story, because at that point we were, the two of us lost in sort of a wave of emotion with nobody to talk to in a community that thinks that infertility is essentially a taboo subject. And, everyone, and, for good reason and bad reasons, but, people are allowed to keep their lives private, and whatnot. And this is definitely a very private situation. But we were lost. I mean, we typed in, Jewish infertility, and, maybe one site popped up, and it's like, okay, here's what you do. And it was all information about, if there's something wrong with the women, not the men, if the woman has PCOS, if she has some endometriosis, if there's, whatever else is wrong, it's all women centric. And there was really nothing about, well, what happens when a man's semen analysis comes back at 0? What are the options? So at that point, after talking with Ellie Solomon, Ellie got on our case, and she's like, forget that urologist. Here's who you got to go see. Let me set it up. And Abigail, because this is with the man, you'll be subject to a lot of testing and whatnot too. Here's the reproductive endocrinologist you're going to see as well. And just like that, in 2 months from having zero hope about anything, we were just pushed into the doctors that we now call our family, for really enabling us to have the family that we've always dreamed of. My journey, didn't really stop there at the doctor's point. After the doctor, I walked into the new urologist's office. He looked me up and down. He said, this is what you have. This is what's wrong with you. Let me get a blood test to confirm it. And he was right. And I have a chromosomal abnormality that, prevented me from producing sperm normally. And he said, okay, look, it's not the end of the world. There's still options. There's still options for you to have biological children. And he's like, this is the procedure. It's called the microtesty procedure. I'm sure you may talk about it going further with the doctors. He's like, let's do it. We'll go into Dr. Werthman will probably speak more about it as it's his area of expertise, but he said, let's do it. We'll go into the testes. We'll find sperm. All we need is one. And he did it, and he found some sperm, and we tried the IVF cycle in conjunction, and it didn't work. And then we sort of, was like, okay, well, now what? He found sperm. It didn't work. Like our situation is now, again, back in the negative. So he said, we went back to the urologist for our consult, and he said, it's okay. I can go back in. I only went in on one side. I'm going to go on the other side, see if I can find anything. And from there, we'll go on. And I don't know, he found sperm on that second side. We did it again. And now we have, a couple of kids, but, it's a good journey, but it's really just a huge roller coaster of emotions. It's a constant feeling of like, well, nothing ever works out. Why should I continue to hold out? Why should I continue to have hope that something might work? I guess on a personal side, it's, sort of this just complete feeling of uselessness, of just being even just a burden to have around, because, I'm not essentially on doing my job as a man to have a family, I guess, the normal way, if you will. But it's hard. It's hard, but that was essentially my journey in a nutshell.
I appreciate your openness with us and honesty with us. I'd like to know from you, is a part of that story and a part of, first of all, that isolation of feeling it in the community like that. I'm wondering if you could share with us, first on a communal level, what did you find the hardest as a member of a Jewish community? What did you find the hardest to manage?
I guess the hardest to manage was that, we're in our 30s and we live in Washington Heights. There's a nice young community here. Essentially the year that we were trying on like a practical level to have, our first child, everybody around us was pregnant. Everybody around us was giving birth. We were even, Abigail writes about this story in her blog, but we were at a Shabbos meal, a Friday night dinner meal. And everybody was sort of going around the table saying, oh, like, what do some people have in common that some people don't? And one person said, oh, like, we're all pregnant and you're not. And it was just like, thank you for pointing out the obvious. So it was definitely just tough at that point, living in a community where essentially it seemed like every other week someone was popping out a baby, which is great. And, I know that this is maybe a theme in general that people, I am happy for the people who are giving birth and starting their own families, but at the same time, I'm sad for what is essentially the loss of my own. So that was definitely the hardest part of or not the hardest, but that was definitely one of the hardest things in our community. And I think the second is just the sort of like, it has to be kept a secret. It's hush hush. Like nobody can know about it. It's private. And if we do want to share it, like how can we go about and share it? Do we share it? Who can we trust to share it with? You know, just, I don't know, like, and then at the same time, like, okay, we want to share it, but we don't want sort of that pity, like, oh, poor them, they can't have a kid. Oh, poor them, it's going to cost them $100,000 to have a kid. Like, it's just, you know, and I mean, yeah, I mean, the other hard part was that one of my old rebbe, my old rabbis was visiting, and he's like, oh, I see you're still in the Heights. Like, you didn't want to buy a house, you don't want to move out. And I'm like, well, I mean, I don't think any of my other friends had to spend $100,000 to have a kid. So he's like, oh, I didn't realize. And it's like, okay, but like,
why didn't you?
Why'd you ask the question? Like, I'm obviously here for a reason.
Mm-hmm.
I mean, the Heights is nice, but you know, as most of my friends here, it's like, we got to get out.
Mm-hmm. Mm-hmm. And I think about that also from like the ritual space perspective. Like, what was the hardest space for you? I hear that in the rabbinic, you know, from leadership. What else would you say? And then I'm going to move to the next one of the other panelists. But what would you say was the hardest space for you from as a religious community beyond the Shabbos tables? Let's say in ritual, in synagogue spaces, in shul spaces. Was there anything there that specifically you want to like bring to the fore as like this was the moment that was so painful?
Yeah, I mean, davening was very hard, and it still was a little bit hard. But davening was very hard. For me to get into. We were going through this. It was I don't know if it was I think it was after the first microtesty surgery, before the second one. And it was the first night of Slichos, you know, in Elul, you know, or before Rosh Hashanah. And I walked in, I opened my Slichos, and we got to, you know, Hashem Hashem Karachum Mechanun, and I just couldn't say the words. And I sort of just broke down there crying, and then I left because that for me was just, you know, at that point was, you know, the God who is merciful, you know, where's the mercy? Where, you know, where's my salvation? Where is this thing that should just be so easy and natural and just, you know, especially in the area that we are, and just, you know, the commandments to be fruitful and multiply. It's like, where's my mercy? And I just left, and I couldn't say slichos that night. I don't honestly think I said slichos the rest of that year. And that for me was the hardest point of davening.
Thank you. Dr. Petok, would you like to address that? I'd love for you to start talking with us about some of the things that you hear from people who share with you their experience either with male factor or in supporting their wives or themselves through the process of infertility. What are we hearing from the men?
Sure. Well, first of all, I want to thank Akiva for sharing his story, because this is a very important story to be shared, because you're not alone. Obviously, if 40% of infertility is male factor and another 15 or 20% is combined, there's an awful lot of male contribution to worldwide infertility. And yet men do not talk about their stories. And for all of the reasons that Akiva was talking about, it's incredibly embarrassing when your body is not doing what it was supposed to do, what you always believed it would do. You mentioned, Akiva, the sense of loss, and I hear this from men all the time when they are willing to open up and talk about it, because it's a very difficult thing to do. Men in general have fertility as a confirmation of their virility. So if you are unable to conceive, it means you're no longer virile. Now, that there's not a one-to-one correspondence, obviously. If you're unable to conceive, it means that one sperm hasn't been able to get to that one egg. I mean, when you break it down all the way. But with a belief system, and of course, you know, if you grow up Jewish, having a family, and if you grow up in a very religious home, having a large family is very important. And if you're unable to do that, you've somehow failed and been failed at the same time. And I think Akiva was speaking to that. And I hear that frequently from men, that I have failed, but my body has failed me, And I mean, in some cases, we even wonder who or what else has failed us. So it's a stunning thing to get that diagnosis. And as you mentioned, the first doctor who provided you with the diagnosis probably didn't do infertility for a living. I'm sure that when Dr. Werthman talks to his patients, it's a very different conversation because he has a greater understanding of what goes on. And that's also problematic. And I guess another thing is that because men do not share their stories in the way that women do, it appears that you are absolutely alone. And as I said at the beginning of my comments, hardly alone. Just you don't know that the other men are there. And I noticed, the pictures on the screen tonight, there are a number of men here, and I think that's fantastic because it's an opportunity for men to hear a story, to know that this does happen. It's abnormal in the sense that it occurs infrequently. Infertility only affects about 12% of the population, but it happens frequently. So that it is not abnormal in that sense. I guess the other half to answer your question, Dvora, is in terms of supporting spouses who have fertility challenges. We're men are brought up to be strong. The sturdy oak. We handle everything, and we do that for our wives, and we have to be strong for them. And so even if it is not male factor, if it's female factor, and a wife is grieving a loss of fertility, we have to feel that we have to be there for her and not have our own feelings come out. When in fact, I think nothing could be farther from the truth. The more women I've talked to, the more I've begun to appreciate that a man who shares his sense of vulnerability, his sense of loss, his sense of sadness, is being very strong. And while they may not be in the same place emotionally at the same time, to know that, yes, this has an impact on me as well as on you, I think is comforting in a strange sounding sort of way. Not the usual put my arm around you and tell you everything's going to be okay.
Right. I mean, I think you and I had discussed this a little bit, this idea of how critical it is. I hear from the woman's side, the sense of like, maybe it doesn't, like, I would wish that he could share with me in my sadness, that when he stands over there and acts so stoic and acts so strong, that I feel actually more alone. I don't feel necessarily supported, but when he is somehow joins with me in my sadness and expresses his own sadness, then I feel like I'm not as alone as I was before. And yet when you talk to the guys, they'll say, you just take care of my wife. You just make sure she's okay, right? Instead of acknowledging that when he can kind of be present and vulnerable with her, that is actually when she's most okay.
Go ahead. Well, I think what you're speaking to is our sense as men of being incompetent at comforting, right? It's not what we're trained to do. On the other hand, what you're saying, and what I hear from women all the time is, comforting doesn't mean telling me everything's going to be okay and we'll figure this out, which is what guys do. We're problem solvers. It's I'm sad with you too, and I'm with you in this. We are a team. And in fact, what you find is that as couples do grow closer together through this challenge of infertility, when they're able to communicate in an open sort of way and share about the fact that this is incredibly sad. And have some kind of hope, and that requires being connected with the right providers who know what to do.
So can I ask you more directly, when there is male factor infertility, can you talk to me about what you would guide his wife? And I recognize, I just want to acknowledge that we are talking about primarily heterosexual coupling here, for the purpose of this conversation. So can you talk to me about what you would speak to his wife about in terms of how she can also be acknowledging and supporting his pain, because sometimes that conversation, I think, also can get very confusing for her.
It can. I think it's important that she understand. Of course, he's got to be able to say, look, this is hurtful to me too, so that she can comfort him and be strong for him in that way. And being strong isn't necessarily saying everything's going to be fine, we'll be just great. It's being strong is being able to share those feelings, that, this is sad and it's hard. And we may not know what to do. And perhaps the best thing to do is to seek some advice. Also, to share the fact that, as Akiva was talking about, going to shul, being in social settings can be very, very difficult when everybody else is having a baby and you're not. And even if it's your best friends or your brother, your sister, you can be happy for them and sad for yourself at the same time. And sometimes we have a hard time, whether we're men or women, holding those two thoughts, those two emotions in our hearts and heads at the same time. And it's absolutely possible to do both.
Mm-hmm.
So
Yeah.
I would say to her, I would say, look, it's likely that he's feeling pain, but it's also likely that he's not going to be able to come to you directly with it. That's a private conversation with her.
Mm-hmm. Mm-hmm. But we also, Akiva, I was wondering if you could respond to that as well. What did you find, I guess I'll focus on the positive. What did you find to be the most helpful from your wife? What was it from Abigail that really said, like, this is what helped me stay connected or feel very supported? And in that way, also being able to share with other men out there, this is what worked for us.
I think it's like what Dr. Petok was saying, was that it became sort of a we issue instead of a me issue. Mm-hmm. From the beginning, when this was you're sort of in that shock phase before seeing the second urologist, I had suggested to Abigail, it's like, look, I'm useless. I'm feeling really bad. Why don't you just get a divorce? Like, I still love you, but like for your own happiness, just go your own way, have a family, don't subject your body to this. Don't go through all this. And she slapped me across the face and she said, don't mention that again. This is something that we're destined to go through. We're going to do it together and we're going to succeed. And that really was just sort of put that resolve in me to just, okay, you're right. I'm not going to bring it up again. We're going to get through this, and what will be will be.
Akiva, I think that's such an incredible common reaction. I'm useless to you. You should go find, some would say, a real man, one who's capable of impregnating you. And I love the fact that I hope she didn't hit you too hard.
Right. I wouldn't normally condone domestic violence, but maybe in this case, we'll give you permission.
Well, a little pat,
bit.
a little pat that says, come on, we're in together. This is a team effort.
Right. Right.
Yeah, no,
that concept of we-ness is beautiful. Yeah.
Yeah.
Dr. Werthman, I want to come back to you and ask you a little bit more about the treatment piece. Can you describe to those that are listening, perhaps that are not familiar with what a microtessie is? That definitely is one of the things that I hear the most about in terms of treatment. Can you explain how that works?
Yeah, well, before I do that, I just want to talk a little bit about a couple of things. So number one, it's very difficult to be on a call with Dr. Petok because he really hits all the points very nicely. So from that standpoint, he's a hard act to follow. But when it comes to Akiva's specifics really bring up some very interesting points. One of them is that he was azospermic, which is on the more severe or worse type of cases of infertility. And it leads me into going back to the definition of infertility. Even men who have no sperm in the ejaculate are not infertile anymore, as Akiva is an example of, right? So maybe 30 years ago they were infertile, but now maybe it's called subfertile, or where technology has advanced to such a great degree to allow men who could never have been fathers 30 or 40 years ago, and allow most men who couldn't have been fathers 30 or 40 years ago to actually conceive. And the realization that, number one, men who don't have any sperm in the ejaculate will most often still have a small amount of sperm production occur within the testicle itself. And then the technology of ICSI, whereby you're able to pick up one sperm and inject it into one egg, is very, very powerful in allowing those men to become fathers with a significant condition. So that's number one. Number two is what both Akiva and Dr. Petok highlighted, which is Akiva's experience with the first doctor. So it sounds like the first doctor was misinformed or uninformed in terms of what the treatment could and should be, and he didn't offer any hope. And it sounds like he was not very supportive. It was almost like, I can't do anything for you, so therefore you should move on, do something else. Not, hey, what can be done for you, but I can't do anything for you. And there's a big difference in that. And I think this is where the hope comes in. Because if men who have no sperm can still have hope, and it's not false hope, statistically, most men who have no sperm are going to have sperm found on a microtesty, then what does this mean in the bigger picture? And that dovetails into your organization's name, which is Yesh Tikva, that you have to have hope. And I'm going to eventually get to answer your question about the technical aspects of the microtesty. But at the end of the day, and I'll share a personal story with this audience after I answer your question, about hope and about, I would imagine, a predominantly Jewish and Orthodox audience, about hashkafa. So microtesty is based on the realization some years ago when IVF came into play that men who are azospermic, especially men who are azospermic because of poor sperm production, there's two reasons or categories for azospermia. One is sperm are being produced normally in a testicle and there's a blockage and the sperm can't get out, versus having very low or abnormal sperm production. And microtesty, clearly that's the worst scenario. And microtesty is a procedure designed to find sperm in men where production is very, very low and hampered. And the idea is that the testicle, I think we need to talk a little bit about it, the anatomy of the testicle to understand this. And the example I give to patients, because they're men, most of them have unwrapped a baseball when they were children. And so the testicle is somewhat analogous to a baseball in that it's got sort of this white hard covering with blood vessels that look like the red laces on it. And when you open it up, it's basically a ball of twine wrapped up. Well, the testicle kind of looks like this, except the inside is microscopic twine, and we call that twine seminiferous tubules. They're hollow, and inside the wall of these little tubules is where the sperm are actually produced. And what we know is that in an abnormal testicle, sperm are made in some tubules and not others, whereas in a normal testicle, sperm are made all over in every tubule. So what we tried to do is we tried to figure out a way to be able to identify the areas inside the testicle that would have sperm production, because we don't want to damage the testicle and remove big pieces of it, and we want to get a higher yield. And so if these little seminiferous tubules, these microscopic structures, look different in appearance, the ones that make sperm and the ones that don't make sperm, then it would make sense if you can actually magnify them and see what they look like. You could understand and create a little map of where the sperm are and maybe where the sperm aren't. And indeed, this has been a very, very successful technique in helping locate areas of sperm within the testicle in men who make very, very few sperm. So few that I will tell you that I have had patients where literally we searched for quite a long time, found 2 sperm, and I'm thinking of a specific patient, and with the 2 sperm we actually found, the patient had twins. So we're getting down to that small of a capacity. Unfortunately, about 30% of men who are azospermic, because of production problems, we call that non-obstructive azospermia, will not have sperm produced or found on a microtesty because they're not producing sperm. But 65–70% of men, even in the worst scenarios, will have sperm found, and that's a fairly big number. Going back to hope, I'll share with you, and I share with my patients. So my wife and I actually took quite a long time to conceive. Took about 4 years before we gave birth to, my wife gave birth to or conceived our daughter. Took 5 years before she actually gave birth. And I'm in the business, so I'm not so worried. And it was pretty unexplained. And I'll share with you a story that I experienced with a patient of mine who moved here from Israel, and he was a former Israeli tank commander. And he was azospermic, and we did a microtesty on him, and we found sperm. And like Akiva, the first IVF didn't work. And so I was going to Israel, and I said, you know what? I'm going to Israel. I'm going to go to Amuka, and I'm going to go visit the kever of Rav Yonatan Ben Uziel, who the anniversary of his death happened to have been last night. So Rav Yonatan is a tzaddik, and couples go to him, or people go to him to pray for a shidduch, but some couples go to the kever and to pray for help with fertility issues. So I went there and I said, okay, you know what, I'm going to go and say a prayer for this patient. And I came back with a little amulet type of thing. Not that I thought that it was going to do anything, but just, hey, I went, you know, here, take it. Okay. So much like in Akiva's story, Rosh Hashanah comes around in year 4, and my wife's still not pregnant. And at this time, she's getting very, very antsy and upset and emotional. And I went to work out. And on the way out, bear with me, I know it's a bit of a wild ride on this story. I went and I couldn't find my wallet on the way out. And I'm looking all over for my wallet. I went back to my sister's house because I was there earlier. I went back to the gym. I went to the alley where I was parked. Looking around, I can't find it. And there's a little restaurant next door. And I thought, maybe someone found my wallet and came and turned it in. And as I'm walking into the back door of this restaurant, somebody comes out, and it's dark now, night's fallen. And he says to me, Dr. Werthman, do you remember me? And I look, and I was like, of course I remember you. I was at your son's bris 5 or 6 years ago. He starts crying. He opens up his wallet and he says, I have something to give to you. I've been holding it for all these years. He opens his wallet and he pulls out the amulet and he says to me, I want you to give it to somebody who needs it next. And he said, I can't believe that I had kids. It's like a dream. Sometimes I go into their rooms and I have to actually touch them to think it's real. That's so painful and so long was this journey. And so I took this amulet and I gave it to my wife.
Oh no, did we lose him?
Looks like it.
Oh shoot. Right at the crux of the story.
Let me jump in because I want to say something that Dr. Werthman didn't say, probably out of modesty.
Give 1 second. Give me 1 second because I want to just make sure. There
he is. There he is. Okay.
Let's let him finish the story and then I'll come back to it, I promise. Are you okay, Dr. Werthman? Right at the height of the story. Don't forget to unmute your phone. Unmute the computer. You're muted.
Okay.
There.
How about now?
Okay. Yeah, you're good. Right.
So in any event, I tell my wife this story, and we're now through the holidays, and it's Shabbos Bereshit, and we conceive on that Shabbos. And so whatever you believe or don't believe, it's a story of hope. And I had to go around from place to place looking for my wallet, to run into this old patient who shared with me his story again and gave me back this thing. And that was my sign that there's hope and this is going to work out. And so I think at the end of the day, that hope is going to be different for each individual person. That was my hope, my affirmation. And maybe for Akiva, it was something else that he was able to hold on to. And I think for every couple, it's going to be different. But the thing is to hold out for that hope. And sometimes the journey is arduous and it's long and it's not straightforward and it's expensive and it's emotional. But you got to have hope, because without hope, the process just stops.
I'd like to address that concept of hope, and I so appreciate that. I'd like to address that concept of hope because I think that one of the things that I hear from people, my clients especially, will say things like, I just don't feel very hopeful and I'm kind of going through the motions. And sometimes as a therapist, I will say things like, is it okay if I hold hope for you? Like, I'll hold it on your behalf. But I think a different way to frame it also that I think is valuable and that we can help offer this to community as well, is that I think just the fact that you're willing to walk in that door again, that you're willing to go to the doctor, that you're willing to get injections, that you're willing to have medical procedures, you wouldn't be able to do that if there wasn't some undercurrent of hope within you that has some semblance of a belief that this could possibly work. And so even if you don't feel that hopefulness, that perhaps just the action of caring for yourself and caring medically for yourself really speaks to that hopefulness. And so just wanted to kind of bring that up as a perspective. Dr. Petok, I know you wanted to jump in and say something as well.
I did. I love the story, Dr. Werthman. I think it's beautiful. It's beautiful. I have another story that doesn't, it's not quite as beautiful, but I'll tell a little bit later on. But what I wanted to say is that when you listen to your description of microtessie and you see how complex a process it is, and how delicate a procedure it is, it means that it requires somebody with exceptionally good training. And I think that speaks, and it just by way of contrast, you know, the first urologist and the second urologist Akiva dealt with, my guess is that the second one had advanced training in reproductive urology. He was a member of the Society for Male Reproduction and Urology, or some organization like that that specializes in that, and had exceptional training. And it, you know, it's for me, I want to get the best care I can. So if I've got a problem with my heart, I want to see a cardiologist. If I've got a problem with my my gut, I want to see a gastroenterologist. If I've got a problem with my fertility, I want to see somebody who is trained and specializes in that. And so I think that becomes very important because you can tell, listening to Dr. Werthman, he knows how to talk to patients about something which he understands on a very personal level is incredibly difficult. And I think that requires a physician with compassion as well as an extreme amount of knowledge and skill. So that's
Absolutely.
what I wanted to say about that.
Yeah, for sure. And you speak to that idea of you got to have an expert. Like, you know, for those of you old enough to remember or to know the music of the Music Man, you know, you got to know the territory. And if you don't know the territory, did anybody get that reference? Hopefully somebody out there.
I got it.
Like,
I'm old enough.
You're older than me. But I think that, you know, but I think that you have to know the territory. If you don't, you really have a chance of creating tremendous emotional harm and also delaying the process. So it would encourage, if anybody is on the call and is starting this process, to just, you know, really pursuing to find who are the experts, what is their training, you know, where did they serve and where have they done their time, and what is it about them that makes them considered an expert. You know, recently I was looking at, I'm aware of credentials of somebody who I know is like highly rated, top doctor, amazing. He's not board certified in reproductive endocrinology. And it just makes me wonder, why not? Like, you've been in practice for so many years. That's just a standard that I would expect of every one of my physicians, to be board certified in the area that you practice. And I, you know, sometimes I wonder if I have an obligation to tell my patients, by the way, the doctor you're going to who you think is so amazing, like, isn't board certified, but that's a different story. So just, you know, finding the expert in your communities, finding the experts in the community next door, to know who is the best person to go to in order to get the treatment that you need. Akiva, I want to come back to you with a question. I would like to know from you what you felt from a community level, or what did you feel, I'm going to put it in the negative. What did you feel was missing in terms of awareness, education, sensitivity? Where do you feel like we globally could have done better?
I don't know. It's tough, and it's. I think because the issue is so private, there's really there isn't that awareness for people to come over, and at the same time, like, I don't know, do you really want people to come over and be like, hey, you know, is your plumbing working? Like, I don't know, you know, like, you know, is you know, what's going on? I think, I guess maybe the awareness comes now in a society where infertility is now being pushed to the forefront, and people are made more aware that this is actually a larger issue than what was previously recognized. Would be not to ask a couple like, hey, you're young, you know, your parents want grandkids, when is it coming? And it's like, that's not an appropriate question anymore to ask anybody, regardless if they're going through fertility issues or not fertility issues. I think it's just, you know, what is appropriate to say and not appropriate to say in just common conversation. That I think would be the best in terms of global awareness.
Can I jump in?
Yeah,
Sure.
please.
I think you're absolutely right. Global awareness is important. And I think, we have a responsibility. I know Dr. Werthman and I probably have similar thoughts about this, in that because we work in this field, it's important to educate other people, not patients, but everybody else who interacts with patients. So Rebbeim need to know about this.
Yeah.
Teachers need to know about this. Your grandmother needs to know about this. Not that it's you, but that this is a global problem, and that a certain sensitivity to people. And I like what you said, Akiva, that, it's not new. You've been married 18 months. How come there are no kids? This is an inappropriate thing to say to somebody. If you want to say something, you say, how are you doing? And let them start that conversation if they're comfortable doing it. Anyway, that's.
I think I'd like to also kind of, in just the last few minutes, I do intend to finish on time at 9:30. I would like to bring in kind of relevance to the current situation. So one of the things that we all know now, first of all, that many of the clinics were shut down. So many people that were pursuing treatment, really everything was kind of cut and stopped for many up to 3 months. We should acknowledge and be aware of the pain that caused, and the deep sadness that caused a delay for so many people trying to conceive. But there's a piece of this that I wanted to bring up as from a perspective of guidance. When we have right now, when women are going into clinics for treatment, their partners are not allowed to be at bedside in many of the clinics that we're working in. So they're going in for IUIs and transfers and retrievals alone. And I thought that, it's so difficult anyway sometimes for couples to communicate each of their own struggles in these circumstances. But when a woman is going in alone, I'd like to hear from each of you, what would it be a good idea, to offer as points of connection? What should you say to your wife, or what can you do for your wife? From my perspective, one of the things I like to consider is, if you're not going into treatments with your wife, make sure that when she walks out of the building, you've got a cup of hot coffee, a mug of hot chocolate, her favorite chocolate, a Post-it note on her dashboard in her car, something on the mirror in the bathroom that says, I love you and I thank you, and I appreciate you, and I'm thinking of you, and checking in with her. If you can FaceTime while they're in the treatment rooms, with permission that some are wary of doing that because they don't allow certain, kind of technology into the treatment rooms, but asking for so that you can have your partner next to you, albeit technologically next to you. Dr. Petok, what do you recommend to help increase, especially at a time like this, when there is this physical separation, unfortunately? What are some ways that a spouse can support his wife going into treatment?
Well, everything you said for starters, but prior to that, I think it's incumbent upon each of us to ask our spouses, how can I best support you during this, whatever the challenge is? And then have some ideas. If, what would make sense? Could you send me a text when I'm about to go in? Would you, the Post-it note, we don't have to do expensive to be very connected to our spouses. I'll make dinner, whatever, what you tell me what would be the most helpful.
And I would imagine that would really go both ways as well, right?
Oh, yes.
If in whatever circumstance we're dealing with, to ask each other, what can I do to support you? Because I want to support you. Help me support you properly.
Sure. And you're right. The technology, we are required to maintain confidentiality for our patients, whether we're medical providers or mental health providers. And so we're not bringing FaceTime in unless it's HIPAA compliant, which FaceTime is not. But there are other little ways to be connected, and that I think is the critical thing. You don't know what to do until you ask, unless you're really good at reading minds. And I don't know about you, Dvora, but they didn't offer that class when I went to graduate school.
No, they didn't. I need one of those amulets to help me figure that out. Akiva, what do you think what would your opinion be and thoughts be as kind of suggestions for connection?
I think you touched about, either you or one of the doctors touched about this earlier, but I think it's that sort of vulnerability and really just opening up. I know that a lot of my personal, support was perhaps lacking because I am sort of an emotional bug, and it's just the times that I did open up and I did cry and I did, scream and I did whatever, that was the highlights. That was this strong connection now just came about, being like, oh, you're actually a human. Like, oh, you're actually now a part of this process. Oh, like, thank you for crying, because now I know what you're feeling. And now we can both, you know, okay, you're crying and I'm crying, and now let's cry together to get to where we want to go. So I think really just that openness, that vulnerability, it's very important. And I mean, I know, you know, sort of men are sort of taught, learn not to cry, especially in public, especially in front of somebody else. And it's really important not to keep things in. I mean, one of the best things that happened to me sort of while we were dealing with this, but also sort of post, was Abigail forced me to go to therapy. She's like, do not come home until you see a therapist. And that was, I know, she slaps me, she sends me to therapy.
She slapped you and then she forced you to therapy. What are we going to do? Amazing. I need to meet this woman.
But it was really one of the best things to do, because that allowed me to open up, to become more vulnerable to somebody else, and guide me into how to become more vulnerable and comfortable sharing my feelings with my wife, with Abigail.
Akiva, I have to tell you that by being vulnerable, it's a strength. It's quite paradoxical, but when we admit to our spouses our vulnerability, we gain a certain level of strength. Particularly within the relationship, we strengthen the relationship.
Absolutely. Dr. Werthman, any final words as we finish out the evening? I know you're not the therapist, but I'm sure you've seen a lot. What have you seen has been the most kind of valuable what do you see what brings couples together in their communication or in their content? Don't forget to unmute, just unmute.
There we go.
There you go.
So, you heard from an expert in this regard, and everything that everybody said, obviously, is very, very important. I'm going to add in something with a little twist, which is prayer. So both on an individual level and on a communal level. So how do you feel supported in your community? You know, I belong to two shuls. I belong to Rabbi Muskin shul. I think Gila knows him. The Young Israel, and I also belong to the Happy Minyan. And one of the things that they do is, especially around holiday time, is they take time out to pray for people who have needs within their community. And that includes couples wishing children, couples needing shidduchim, and so on and so forth. So they're not singling people out, but at the same time, when you go and you know and you have a problem and they're praying for you, that you feel supported, and it's really a pretty powerful thing. On an individual level, I know for me personally, if I've got something going on in my life and my wife gets up in the morning and I see her praying and davening, and she says to me, you know, I just prayed that things work out, that's about the best thing she can do for me. Mm-hmm. And I think it's what you can do for someone else when you can't be physically next to them. You can pray for them, pray for their peace, pray for their comfort, pray for a successful outcome. But I think it's very, very, very powerful, and let them know you're praying for them.
I love that idea, and I really appreciate you bringing that content and that spirituality to this as well. And I'd like to close with one very brief story that I heard from a client of mine. She was a woman that had recurrent losses, many, many, many losses, and pregnancy losses. And so one of the questions that was on our conference call was, well, every time I pass by a woman who's pregnant, I'm in pain. It hurts me so much. I want to avoid her. I don't know what to do. And I feel like I'm a terrible person because I'm so triggered by seeing this woman who's pregnant. And this initial woman said the following. She said, you know, one of the strategies that I have done is that when I see a woman who is pregnant, I make the decision to pray for her. And every night I have my list of women that I know are expecting, and I pray for them every night. And then when that woman gives birth, I pray for her, and I pray for the wellness of her child, that she should have a healthy pregnancy and a healthy baby. And so when she does give birth to a healthy pregnancy, after a healthy pregnancy, and she has a healthy baby, she said, I feel like my hand was in there somewhere, that I had some part of that I had some influence over that. And that gave meaning to my prayer. I couldn't pray for myself anymore. She said it was too painful to pray for myself, but I can pray that she should have a healthy child. And I think that's an extraordinary thing, to find the space that works for you. If it's praying for somebody else, if it's praying for yourself, if it's reaching out and getting support and getting help, if it's making sure if you need therapy, connect to the people that can give you, that are trained and can give you, you know, good support. Try to find that guy that you can share and be vulnerable with, so that your male and female friends will know that how they can potentially support you. And hopefully we as an agency and as an organization, that Yesh Tikva can continue to grow our education, sensitivity awareness, training of leadership and community, so that we can really fully support and hold the intensity of those that are experiencing this kind of struggle in their lives. And hopefully we can reach more and more of you over time, and continue to send our well wishes through our prayers and well wishes through the phone lines, through the Zoom lines. Akiva, thank you so much for being here with us and sharing your story. Dr. Petok, thank you for being here tonight and sharing your experience and expertise. And Dr. Werthman as well. Outstanding evening and preparation. Gila, thank you for taking the lead and pulling this all together with me. It has been an honor and a pleasure. You are welcome to reach out to me directly if anybody on the line has some individual questions. Gila or I are more than happy to answer questions and direct you to the experts. So Gila, I'm going to put I don't know if I can. I'm happy to put it into the chat, or you can just reach out to Gila. I'm sure everybody has her information through Yesh Tikva, and to follow up as well.
Everyone.
Absolutely.
And sending out the information so that everyone can
Excellent.
access.
Excellent.
Thank you, Dvora.
Thank you, everybody. My
Thank
pleasure.
you.
Thank you, everybody.
Thank you.
Good night. Stay
Good night.
healthy. Stay safe. Have a wonderful summer. All right.
Well,
Good night.
Shabbat Shalom, everyone.
Shabbat Shalom.
Oh,
And
yeah.
to you. Take